The broadcast is now starting. All attendees are in listen-only mode.
Thank you for attending the webinar. As you know, our topic this evening is what your doctor hasn't told you about cholesterol. And your doctor hasn't told you because your doctor doesn't know. That's a little bit presumptuous on my part, but I really believe it's the case. I think very few doctors know about a lot of this information. Have you ever seen this ad? This ad used to run on TV. I got this off the internet. This is an ad for cholesterol-lowering medication. By the way, let me introduce myself. My name is Dr. Joseph DeBay. I'm a board-certified nutritionist practicing in Great Neck, and I consult with people in my office and also long distance by telephone and internet. I do these webinars on a regular basis. By the way, if you want to type in a question, you can do so with that control panel. It should be on the right of your screen, and I'll be answering questions at the end of the webinar. This webinar is a shortened version of what I've done in the past. I have about 300 slides that I was picking through up until about 7:58 this evening. And hopefully things won't be too choppy, but I wanted to give you a lot of information, but try not to overdo it. Okay, so Vytorin is a medication. It's actually a combination of two medications for lowering cholesterol. And this ad claims that there are two sources of cholesterol, food and family, and Vytorin treats both. You see, in addition to the cholesterol that comes from foods you eat, cholesterol is also produced naturally in your body based on your family history, which means your mom, your dad, even your grandparents can influence your cholesterol. This is the liver. There's an enzyme in the liver called HMG-CoA reductase, and one of these medications in Vytorin, the class of drugs called statins, work by inhibiting the action of this enzyme that makes LDL cholesterol. Lipitor and Zocor, Crestor, those are a few of the statin drugs. That's the way they work. They inhibit an enzyme in the liver where cholesterol is made. The other component of Vytorin is Zetia. Zetia inhibits cholesterol absorption from the intestinal tract, but at the same time it can also inhibit absorption of fat-soluble nutrients. The statins, by inhibiting that enzyme, not only reduce your LDL cholesterol, but can wind up reducing your steroid hormones, can have a negative effect on your cell membranes, formation of bile acids, which you need for elimination of fat-soluble waste products and absorption of fat-soluble nutrients. This can wind up impairing your vitamin D synthesis and your coenzyme Q10 levels. So this is my emphasis. You see, in addition to the cholesterol that comes from foods you eat, cholesterol is also produced naturally in your body based on your family history. So this ad is trying to get across the point that if you're too much of a lazy slob to give up high cholesterol foods, you can just take medication. If you do avoid those foods and your cholesterol still doesn't come down, then you blame your parents. It's leading us to believe there's only two reasons for high cholesterol: eating high cholesterol foods and genetics. That's a myth. Okay, we're going to get into the actual causes of cholesterol in a minute. Now let's talk about side effects of these medications, some things that aren't commonly discussed. Statins, like Lipitor, Zocor, Crestor, these are HMG-CoA reductase inhibitors. They result in reduced levels of coenzyme Q10. Coenzyme Q10 is critical for your heart function. It plays a vital role in energy production throughout the body, and it's very important for the immune system. Low coenzyme Q10 levels are associated with congestive heart failure. People taking statin drugs should supplement with coenzyme Q10. Statin drugs may also impair vitamin E and beta-carotene levels. In an animal study, these drugs resulted in increased LDL oxidation. We'll be talking about that a little bit later. Decreased myocardium or heart, ATP energy, and creatine phosphate energy production. These drugs were found in a study to cause an unfavorable change in the ratio of different fatty acids. These drugs have been shown to impair insulin sensitivity and result in increased cases of diabetes and worsening of glycemic or blood sugar control. These drugs are commonly associated with liver toxicity. Some of these symptoms and results of these drugs are common, others less common. Liver toxicity is a common one. Headaches, gastrointestinal symptoms, interstitial pneumonitis, inflammation in the lungs, muscle damage, this is a big one. Even 30,000 cases a year of life-threatening myopathy, muscle problems. Decreased libido in men, maybe because of decreasing testosterone levels. You need cholesterol to make testosterone and other hormones. Severe irritability, aggressive behavior, suicidal impulses, cognitive impairment, hemorrhagic stroke, memory loss, global amnesia, dementia. These are things that have been associated with using these drugs. Kidney failure, a 16-fold increased risk to neuropathy, nerve problems, a slightly increased risk to cancers, including breast cancer, cataracts, heart failure, acute pancreatitis, and autoimmune conditions. All these have been associated with use of these medications. Here's a graph showing the incidence of cancer in a placebo group and then a group given a cholesterol-lowering drug. See, there's an increased incidence with the drug. Here's a quote from a published study. The risk of cancer is significantly associated with lower achieved LDL cholesterol levels. Furthermore, the cardiovascular benefits of low achieved levels of LDL cholesterol may in part be offset by an increased risk of cancer. Doesn't sound like a very good trade-off to me. Here's my wise guy cartoon for the evening. Sure, you may be experiencing a few minor effects from the medication, but your cholesterol has never been lower. There was a cholesterol-lowering medication called Baycol, which was pulled from the market because there were a number of deaths that were directly associated with it. These cholesterol-lowering drugs, called statins, are effective in secondary prevention. There's research, experts agree that these drugs do offer some benefit for people who have a history of a heart attack, heart disease. The benefit is mild to moderate, I would say. They don't absolutely prevent recurrence. Actually, there's some evidence that natural approaches do more. But the big question is, how effective are these drugs for the application they're most commonly used for, which is primary prevention, when they're given to people who don't have a history of heart attack, heart disease, people who just have a high cholesterol. Are these drugs the most effective medications ever? In my opinion, no. They're simply the best marketed medications ever. Here's an ad for one of these medications. Lipitor reduces risk of heart attack by 36%. That sounds fairly impressive. You read the fine print. That means in a large clinical study, 3% of patients taking a sugar pill or a placebo had a heart attack compared to 2% of patients taking Lipitor. So they have ways of playing games with the numbers to make it sound more impressive than it is. Back in 2001, I think drug companies found a way to increase their market share. There was a panel convened of so-called cholesterol experts who reviewed data and decided that the cholesterol reference ranges were too high, that for health, people needed to have lower cholesterol levels. So overnight, the pharmaceutical companies had millions of more patients. It's been uncovered that 11 of 12 of these experts on the cholesterol advisory panel had financial ties to the drug companies that make cholesterol-lowering drugs. This is a valuable article I recommend you get your hands on if you want to review this in more detail. from Business Week. I think this is January 2008, all about whether cholesterol drugs do any good. And this is based on the work of a couple of medical doctors. One is Dr. Wright, I believe, from Canada. He's the head of the equivalent of the FDA up there. And he wanted to, he understood that these cholesterol-lowering medications have value for people with a history of heart attack, but he wanted to know if these drugs really had data supporting that they were of benefit for the application they use for most, which is primary prevention, people who don't have a history of heart disease. So he examined the data of the 8 major studies to that point, and what he found was the only benefit, besides lowering cholesterol, the only health benefit was a reduction in cardiovascular events only in high-risk men between 30 and 69 years of age. How much of a reduction? There's something called number needed to treat. And what was found in looking at these medications in this group of men at high risk, based on their cardiovascular risk factors, their cholesterol, blood pressure, body weight, smoking, family history, diabetes, that type of thing. 67 men would have to be treated for 5 years to prevent one cardiovascular event or heart attack. Stated another way, the odds are 66 out of 67 chances that if an individual takes a statin for 5 years, it will not prevent a heart attack. Not very good odds. And these drugs did not reduce total mortality. So in this group of high-risk men between 30 and 69 years of age, if there were some men who were protected from early death from heart disease, there were other men who died early from other causes. There was not an overall reduction in death rate. And there was not a reduction in total serious adverse events. So if there were reduced heart attacks, then there were increased incidences of other serious complications that offset that benefit. There was no benefit for women of any age or men older than 69 years. Why take a cholesterol-lowering drug? What's the goal? Is your goal to be able to brag about your cholesterol number, or is the goal to protect you from dying early or from disability? If the goal is to protect you from dying early, it doesn't make much sense to use these drugs if you don't have a history of heart attack. These studies involved 10,990 women and found no reduction in total cardiovascular events. 3,239 people older than 69 years also had no reduction in total cardiovascular events. Not effective for women, not effective for men older than 69 years. For men between 30 and 69 years, 67 patients need to be treated for 5 years to prevent one coronary event or heart attack, and not effective in reducing rates of dying. So these drugs are obviously hyped. The science doesn't justify the way these things are prescribed. Here's a study that compared the effects of a cholesterol-lowering medication, a statin called simvastatin, versus therapeutic lifestyle changes in supplements. So one group got the medication and traditional counseling. The other group got therapeutic lifestyle changes and red yeast rice, which is kind of a natural statin, and fish oil supplements for 12 weeks. There was a statistically significant reduction in LDL cholesterol levels in both the alternative group and the simvastatin group. No significant differences were noted between groups. The alternative group, it's the diet, lifestyle, supplement group, also demonstrated significant reductions in triglycerides, 29% reduction. Triglycerides are an independent cardiovascular risk factor. They're basically fats in your blood. 29% versus 9.3% in the medication group. And the alternative group had a weight reduction, minus 5.5% versus just 0.4% in the medication group. So in this study, the alternative group was more effective than the medication. Now, there is value in taking red yeast rice. It's not something that I use regularly. I very rarely use it. And I think by the end of this webinar, the reason will become clear. It's not that there's something wrong with the red yeast rice. It's just not getting to the underlying cause. What's scarier than the Grim Reaper himself? A chicken egg. People are afraid of egg yolks. I'm going to show you that that fear is not justified. Here's a quote from a textbook of medical physiology that I learned from, a lot of doctors learn from. Plasma cholesterol concentration usually is not changed upward or downward more than 15% by altering the amount of cholesterol in the diet. If you eat more cholesterol, your body makes less cholesterol. If you consume less cholesterol, your body makes more cholesterol. So you don't typically change your blood cholesterol all that much by changing the amount of cholesterol that you eat. Now, that's not to say that your diet doesn't influence your cholesterol. It's just that the amount of cholesterol in the diet is not the factor that changes your blood cholesterol. 10% of people or so have a significant increase in blood cholesterol in response to increasing their dietary cholesterol. Most people don't have a significant increase in their cholesterol. But we're going to see some interesting information about eggs, one of the highest cholesterol foods, in just a little bit. Okay, very importantly, where does cholesterol come from? Maybe 70% of the cholesterol in your blood doesn't come from your diet. It's made in your liver. Cholesterol is used for vital functions. It's transported on proteins from the liver throughout your bloodstream. It's used for many vital functions, repairing cell membranes and making hormones, other substances. Excess cholesterol is returned in the form of HDL to your liver for excretion. For the cholesterol to be excreted, it's converted into bile acids, and that requires nutrients: taurine, glycine, vitamin C, and magnesium. So what do you think might happen to your cholesterol levels if you're not getting enough taurine, glycine, vitamin C, or magnesium? Then from the intestinal tract, some of that cholesterol can be reabsorbed. And Zetia, that drug Zetia, that's a component of Vytorin, works by inhibiting absorption of cholesterol from the intestinal tract. There are natural substances that do the same thing, plant sterols. You find them in soy and nuts and other plant-based foods. You can take them in supplemental form. And they lower cholesterol maybe about 10 or 15%. They also have some anti-inflammatory effect. There's some evidence they have some cancer preventive effects. They don't impair absorption of fat-soluble nutrients like the Zetia does. Okay, very importantly, what causes elevated serum cholesterol? It's not a Lipitor deficiency. Genetics are a factor. Now, even for the type of cholesterol that's strongly connected to genetics, there are ways to modify that. I have studies, I'm not going to go into tonight, but there are studies showing that even in people with the genetic type of high cholesterol, by making dietary changes, they can lower their cholesterol significantly. At menopause, there tends to be an increase in cholesterol. Your diet has an effect. Too much dietary saturated fat and trans fats. Trans fats are very damaging. I recommend avoiding those. You find those in hydrogenated oils, in breads and cookies and cakes and all kinds of convenience foods. Nutrient deficiencies. We saw that you need magnesium, vitamin C, the amino acids taurine and glycine. If you're lacking those, that can be the cause of your high cholesterol. Low thyroid function. there are many cases of undiagnosed low thyroid function, and that's a common cause for high cholesterol. Toxicity, including chlorine in drinking water, that can be a cause of high cholesterol. Chronic infections, including infections in the mouth, periodontitis, and a stomach infection with a bacteria called H. pylori. These things can result in a high cholesterol. Problems with your insulin and blood sugar can be the cause of a high cholesterol. Too much fat around the middle. Stress, oxidative stress or free radical production and inflammation. Impaired liver or kidney function. So high cholesterol is like a sounding fire alarm. And taking a statin drug or taking red yeast rice without looking for these underlying causes doesn't make much sense to me. So the first thing I do is I evaluate a person and try and look into these possible causes. When we find them, we address them, and we're going to make the person healthier and protect them from other problems, and likely they're going to be feeling better when we correct these issues that are causing their cholesterol to elevate in the first place. And if we still need further reduction, then we can turn to red yeast rice perhaps. We could use niacin. We could use coenzyme Q10. We can use plant sterols, pantethine, polycosanol. There are quite a few things that have research in lowering cholesterol. Do arteries simply become clogged with cholesterol, like your pipes becoming clogged? No, that's not the way it works. We're not going to get into this in detail, but cardiovascular disease is an inflammatory condition. It involves the immune system. Is cholesterol a friend or a foe? Is cholesterol a cause of heart disease or a misunderstood messenger? Cholesterol is a part of every cell membrane. It's essential for brain health. It goes into making a substance called cerebrosterol. It's a building block for steroid hormones, sex hormones, adrenal hormones. It's a building block for bile acids used for fat digestion and detoxification. And cholesterol is a building block for vitamin D. $70 or 80% of the cholesterol in your body is made in your body. Cholesterol technically functions as an antioxidant. Cholesterol only appears to be problematic when it is oxidized. And there's a blood test that can be done to measure your oxidized cholesterol. So it's one thing to know your total cholesterol, or your LDL, so-called bad cholesterol, but you also want to know if your cholesterol is oxidized. There have been experiments done with rabbits early on when cholesterol, the cholesterol connection to cardiovascular disease was discovered. There were studies done on rabbits where they fed the rabbits high cholesterol diets. They fed preformed cholesterol to the rabbits, and they developed cardiovascular disease. Years later, the experiment was repeated, and this time they took steps to protect the cholesterol from free radical damage before it was fed to the animals. And this time, the rabbits didn't develop cardiovascular disease. Native, natural, intact cholesterol is not that damaging. It's when the cholesterol is altered by free radicals and by sugar, a process called glycation. That's when it really contributes to plaque buildup in the arteries. Free radicals interact with the cholesterol and cause it to become problematic. Now, something you don't hear a lot about is the problem with low cholesterol. If you have a cholesterol below 160, you have an increased risk to mortality from other causes: cancer, violence, including suicide, hemorrhagic stroke, digestive and respiratory conditions. And there's an association with many other conditions, including depression, anxiety, bipolar disease, and Parkinson's disease when you have a low cholesterol, autism as well. Cholesterol is a smoke, if you ask me. There's an interesting study done on people with a history of heart attack. One group was put on a Mediterranean-style diet, and they were followed for a number of years. The rate of cardiac death and non-fatal infarction in the experimental group after 46 months, 1.24 per 100 patients per year. The rate in control subjects was 4.07 after 46 months. Hence, the data confirming the impressive protective effect of the Mediterranean diet. So one group followed their standard diet, the other group got the Mediterranean diet, and there was a huge protective effect of the Mediterranean diet. When they looked at blood cholesterol levels in these two groups, there wasn't much of a difference. The protective effect of the Mediterranean diet in this study wasn't related to the blood cholesterol. There are so many other factors that influence cardiovascular disease. I've heard there's actually over 1,000 independent cardiovascular risk factors. People hear about cholesterol, but there are other factors that are even more important. Now, when it comes to cholesterol, there's a lot of detail worth looking into. I'll get to that in a few minutes. Studies on omega-3 fatty acids have found that they lowered blood cholesterol only 2% on average, but omega-3 fatty acids have been found to protect against heart disease, death from heart disease, death from all causes, much more effectively than the statin drugs. So there's more to cardiovascular disease than cholesterol. The Lyon Diet Heart Study, that's the Mediterranean Diet Study we just took a look at a minute ago. Blood cholesterol levels didn't differ between groups, but there was a dramatic protective effect of the Mediterranean diet. Vytorin in one study was found to reduce cholesterol, but result in increased atherosclerosis or clogging of the arteries. Same is true of estrogens and progestins. They can lower the cholesterol, but increase plaque in the arteries. A study found that 80 milligrams of Lipitor lowered LDL cholesterol below 70, but that didn't help the arterial plaque if the CRP was above 2. CRP is C-reactive protein. CRP is an independent cardiovascular risk factor. It's a marker of inflammation. Cardiovascular disease is an inflammatory disease. And the statin drugs have some anti-inflammatory effect. They work in a few ways besides lowering cholesterol. And the reason they offer some benefit may be more than lowering cholesterol, might be to some other factors. For people over 80 years of age, higher blood cholesterol has been associated with less vascular disease. %40 of Americans who suffer heart attacks do not have any of the standard risk factors. Now, when it comes to cholesterol, I recommend doing a comprehensive workup, including a VAP profile. You get the usual, plus additional things. You get the total cholesterol, you get the LDL, so-called bad cholesterol, you get the HDL, good cholesterol, you get the VLDL, which is another type of bad cholesterol. Then you get additional information. The LDL is actually comprised of what's called real LDL, IDL, intermediate density lipoprotein cholesterol, and lipoprotein A. All of those are so-called bad types of cholesterol. When they're high, you have an increased risk to cardiovascular disease. Triglycerides are routinely measured. That's another independent cardiovascular risk factor. When it's high, that's associated with risk. VLDL3 is a subtype of VLDL cholesterol. It's a bad one. That's got a strong connection with insulin resistance. Then we have carrier proteins. ApoA1 is a protein that carries the good HDL cholesterol. ApoB100 carries the bad LDL cholesterol. These proteins are stronger risk factors than the cholesterol numbers themselves. So that people should really have measures of these. And it's important to look at the ratio between the ApoB and the ApoA1. The ratio should be below 0.6. Then with this MAP profile, very importantly, we get a fractionation of the HDL good cholesterol into subtypes HDL2 and HDL3. HDL2 is the more protective type of cholesterol. That's more protective HDL. So you want to have high levels of HDL2. You could have normal HDL, but if your HDL2 is low, you're not really protected. Then very importantly, we get LDL particle size. When you get a measure of your LDL cholesterol, it's a measure of weight per volume, milligrams per deciliter of blood. And that's a result of the number of particles and the size of the particles. If you have large LDL particles, they kind of bounce off your artery walls. When the LDL particles are small and dense, they stick to the artery walls and contribute to plaque buildup, to put it simply. So with this VAP profile, you get a measure of the size of the LDL particles. And if the particles are small and dense, then you can take steps to make them large and buoyant. Insulin resistance causes the particles to be small and dense. So do free radicals, hypothyroidism. So you work on those things to make the LDL particle bigger. Niacin helps to make it bigger. DHA from fish oil helps to make it bigger. And I think there are some other factors as well. High serum cholesterol levels have been linked to increased coronary heart disease, yet the risk of cardiovascular disease in men and women does not increase with increasing egg consumption despite their high cholesterol content. Except perhaps in diabetics. There might be a slight increased risk in diabetics, but for most people, eggs don't increase risk for cardiovascular disease. Why? Here's a study that fed people 3 eggs a day. 29 most postmenopausal women and 13 men were assigned to either 3 eggs or an equal volume of cholesterol-free egg substitute for 30 days. Following a 3-week washout, the subjects crossed over to the alternate diet. So for 1 month, one group ate eggs. Then after 3 weeks of no experimentation, they were given the alternate diet and followed that for a month, and they looked at the results. There was a subgroup of people who had an increase in their cholesterol when they ate eggs, and they were called hyperresponders. After eating the egg diet, hyperresponders had larger, less atherogenic LDL particle and larger HDL particle, with no significant differences in the total number of LDL or HDL particles. So after eating the eggs, some people had an increase in their cholesterol. There was an increase in both the good and bad cholesterol. The increase was due to an increase in the size of the cholesterol particles. And that makes the particles less atherogenic. That means less likely to cause plaque buildup in the arteries. So if anything, eggs would be protective of cardiovascular disease. You see, it's not so simple as eating cholesterol and having an increased blood cholesterol. You have to look at the type of cholesterol, LDL versus HDL, and the size of the cholesterol particles. Regardless of response classification, all individuals had an increase in plasma lutein and zeaxanthin during egg, yet hyperresponders displayed higher concentrations of carotenoids when compared to hyporesponders. Carotenoids are a group of naturally occurring substances. Lutein and zeaxanthin are a couple of carotenoids. These are very protective against macular degeneration, and eggs contain these protective substances. So if you worry about your eyes, you don't want to be cutting out egg yolks. Okay, I mentioned before the ApoB to A1 ratio should be less than 0.6. If it's above that, I get suspicious that a person has insulin resistance. Now, these are some additional cardiovascular risk factors. We're not going to spend a lot of time talking about things besides cholesterol, but these may be more important than cholesterol. Fibrinogen, that's a blood clotting protein produced by the liver. It's produced in response to inflammation. high sensitivity HS, high sensitivity or cardio C-reactive protein. Also an inflammatory protein made by the liver. It's an independent cardiovascular risk factor more important than cholesterol. Homocysteine. That's a naturally occurring amino acid. When it's elevated, it can cause cardiovascular damage. Insulin. Elevated insulin is an independent cardiovascular risk factor. Insulin works in multiple ways to contribute to cardiovascular disease. Hemoglobin A1C, that's an indication of your average blood sugar over the past 3 or 4 months. If that's high, you have an increased risk to cardiovascular disease. It indicates that you have increased glycation going on, sugar-damaging structures in your body. My last newsletter was all about glycation. You can go take a look at my newsletter archive and read a paper I wrote about glycation. I think it's the most underappreciated factor in chronic degenerative disease and biological aging. Lipid peroxides or oxidized LDL, these are measures of free radical damage. Very important independent cardiovascular risk factors. And LP-PLA2, this is an blood vessel-specific inflammatory marker. The C-reactive protein is a general inflammatory marker. It does correlate quite well with risk to cardiovascular disease, but the LP-PLA2 is specific for cardiovascular disease, and it correlates with the likelihood of a plaque rupturing in the arteries. Then we should also measure protective factors. Coenzyme Q10, when high, is protective. Vitamin E, magnesium, and taurine are all very protective against cardiovascular disease. If they're low, you'd want to take steps to correct that. And this is a sample test from Metametrix Laboratory that measures these unusual risk factors. We get the usual total HDL, LDL cholesterol, triglycerides, lipoprotein A, LDL to HDL ratio. Personally, I like to see that under 2. That's a very important ratio. The total cholesterol to HDL ratio is also important. I like to see that under 4. Ferritin, when that's elevated, that's a risk factor. Fibrinogen, we talked about, C-reactive protein. Insulin, testosterone, especially for men. Testosterone is protective. Sex hormone binding globulin, free androgen index, these are related to the testosterone. Magnesium, homocysteine, lipid peroxides, these are measured for free radical damage, and 2 types of vitamin E. This represents an artery. Here's a cholesterol particle, and this is the immune cell. Think of this as this is a white blood cell called a macrophage. Something causes free radical damage to cholesterol. Let's say bad bacteria in the intestinal tract activating the immune system causes an increase in free radical damage. The cholesterol becomes altered. The oxidized cholesterol is taken up by the macrophage, which becomes angry, migrates into the artery wall. It's turned into what's called a foam cell, and it starts the process of plaque buildup in the artery. You get cholesterol and platelets and other cells and calcium building up in the artery wall. One of the things that can inhibit the uptake of oxidized cholesterol by the macrophage and thereby stop the whole process of arterial disease is vitamin D. Vitamin D is very important for cardiovascular health. These are some major cardiovascular risk factors. Physical inactivity, android obesity, too much fat around the middle, elevated serum lipids like cholesterol, triglycerides, hypertension, high blood pressure, diabetes, family history, smoking, omega-3 fatty acid deficiency. Which one's the most important? Smoking. Number 2 is omega-3 fatty acid deficiency. I feel a more comprehensive global analysis of cardiovascular risk involves these factors, not just the lipids and apolipoproteins, but the free radicals, the inflammation, the blood clotting factors, the glycation, sugar damage, and something we haven't talked about yet, which is an important gas called nitric oxide that's in your blood vessels, allows your blood vessels to relax and reduces plaque buildup, may actually help with plaque removal. ADMA inhibits nitric oxide. It's a negative. ADMA can be measured. Nitric oxide can't be measured directly. It's too short-lived. ADMA is an inhibitor of nitric oxide. If you have a high ADMA, you're likely to have low nitric oxide, and ADMA is associated with risk of dying from all causes, and certainly cardiovascular disease is associated with all kinds of cardiovascular conditions. And there are many ways to improve the ADMA and the nitric oxide. I'm going to show you some case studies. A patient of mine, in a month, his total cholesterol dropped from 265 to 170. Triglycerides stayed about the same. His HDL, good cholesterol, dropped a little bit. His LDL, bad cholesterol, dropped significantly. And even though his good cholesterol dropped, the ratio between the total cholesterol and HDL improved significantly. This was without cholesterol-lowering medication. This is without telling Bob to stop eating eggs. All these cases I'm going to show you involved working on insulin sensitivity. Insulin is a major factor when it comes to high cholesterol and cardiovascular disease. Insulin can cause the body to convert HDL good cholesterol into VLDL bad cholesterol and triglycerides. If you have a triglyceride to HDL ratio above 2, I begin to get suspicious. Certainly at 3 or higher, that's associated with cardiovascular risk and insulin resistance. Insulin stimulates HMG-CoA reductase, the enzyme that people take drugs to inhibit. People are taking statin drugs to poison that enzyme HMG-CoA reductase in order to lower the LDL cholesterol. The way I initially work on this process is to use natural approaches, diet, lifestyle, supplements, exercise, to lower the body's output of insulin. Then there's less stimulation to this enzyme to produce LDL cholesterol. This relationship's been known since 1974. There's no excuse for doctors to not be addressing this initially. Here's another case study. In a few months, this patient lost 30 pounds. His blood pressure improved. 140 over 90 is too high. 120 over 80 is more acceptable. His total cholesterol went from 296 to 193, drop of 103 points. Triglycerides were better than cut in half. HDL good cholesterol actually increased significantly. Almost, what is that, about 30%. I don't think there's any drugs that do that. It's unusual for niacin to do that. LDL cholesterol, 236 to 138. Total cholesterol HDL ratio cut in half. And he had an elevated liver enzyme. With insulin resistance, there's often stress on the liver, often fat buildup in the liver. You get elevated liver enzymes. That one was better than cut in half. This was done through diet, exercise, nutritional supplements. The diet and nutritional supplements were geared towards making his insulin work better. When the insulin works better, your body doesn't have to make so much, and all kinds of things improve. Let me skip over that one. Oh, I didn't mean to include that one either. Here's another case study. We took longer to repeat testing on this patient than we needed to. It's just the way it worked out. Another guy where we didn't have him stop eating his eggs, put him on a dietary program to improve his insulin functioning. Start off with the cholesterol, total cholesterol a little bit high at 230, HDL good cholesterol way too low at 30. That should be over 50 or so in men. Laboratories might say 45. I like to see it over 50. It should be higher in women, 55 or so. LDL, bad cholesterol, was 164. Triglycerides were too high at 181. I like to see them under 100. Insulin, I like to see that under 5. His is 21. C-peptide, that's another indicator of high insulin levels. ALT, that's a bad, that's the elevated liver enzyme again. Ferritin, when that's elevated, that's a sign of inflammation. That protein elevates with inflammation. And on this patient, we had a measure of his LDL particle size, and he had what's called non-A. So he had small, dense LDL cholesterol particles. And he went a while before we retested him. His total cholesterol was down to 177. HDL was up by a third, up to 40. LDL bad cholesterol was down to 119. Triglycerides were better than cut in half at 88. Insulin was much improved at 8. C-peptide was much improved. His liver enzyme, better than cut in half. His ferritin showing reduced inflammation. And his LDL particles had gone from small and dense to large and buoyant, less likely to contribute to plaque buildup in the arteries. Again, no medications, just diet, exercise, nutritional supplements. Here's what a VAP profile looks like. So we get up top total LDL cholesterol, and that's comprised of these 3 subtypes. Lipoprotein A cholesterol, this has a strong genetic component to it. I've seen it change dramatically, though, with diet and supplements. The total LDL is also comprised of IDL, intermediate density lipoprotein cholesterol, and real LDL. All of these are bad when they're elevated. HDL cholesterol, that's protective. VLDL, that's a bad one. And we get the subtype of VLDL. We get the VLDL3. That's got a strong connection with insulin resistance. We get the triglycerides. We get total non-HDL cholesterol. That's just another way of looking at the bad cholesterols together. Total ApoB100. This is the protein that carries the so-called bad LDL cholesterol. This is more of a risk factor than the cholesterol itself. We get the LDL size pattern, very importantly. We can have small, dense LDL, called pattern B, and we can have large, buoyant LDL, pattern A, or we can have a mixture, kind of in between pattern A, B. You want to have pattern A. That's the protective pattern. Then we get the HDL broken into 2 subtypes, the more protective HDL2 and the HDL3. This patient had problems in every one of these except for the strongly genetic one. Every one of his other cholesterol markers were bad. The bad ones were high, the good ones were low. And this has a strong connection with the insulin resistance. That's probably behind most of this. And it says right here, consider insulin resistance, metabolic syndrome. Metabolic syndrome is a constellation of high triglycerides, low HDL, high blood sugar, increased waist circumference, increased blood pressure. I want to show you an interesting study. This is a study of 2 different dietary approaches for cholesterol and cardiovascular risk factors. It was done by a company called Metagenics. Ultrameal Plus is a nutritional product that they developed. It's a medical food for cardiovascular health. It's a shake. It's a powder you mix with water and drink. It's like a meal replacement. It's got protein, carbohydrate, fat, fiber, vitamins, minerals, and plant sterols. And they gave one group of postmenopausal women this medical food along with a low glycemic index dietary plan, which is what I use with my patients. And they compared it against the American Heart Association Step 1 dietary program. So both groups of women got the same number of calories and did the same exercise. These were their starting numbers, the Ultramil group versus the American Heart Association group. So the numbers are very similar. They were obese, postmenopausal women with high cholesterol. And after 12 weeks, these were the changes. Start over on the right, the American Heart Association diet group. Total cholesterol only went down 1%. Most of these changes are not significant. The Ultramil group, total cholesterol went down 16%. The LDL bad cholesterol went down 15%. The HDL good cholesterol went up 6%. Triglycerides went down a huge 45%. Total cholesterol to HDL ratio improved by a factor of 1.2. Triglyceride to HDL ratio improved by 2.23. There was a 14.8-pound reduction in body weight, almost double seen in the other dietary group, even though they both consumed the same calories and did the same exercise. The difference is what made up the calories. So in the Ultramil group, they were getting more nutrition with the medical food. They were eating low glycemic index, highly nutrient dense, high in phytochemicals relative to the American Heart Association diet. There was an increase in percent lean body mass with the Ultramil group versus the American Heart Association group. There was a statistically significant change in blood pressure, reduction in blood pressure in the Ultramil low glycemic diet group compared to the American Heart Association diet group. There was a 34% reduction in the inflammatory marker, high sensitivity C-reactive protein. This is something that's not measured routinely, an independent cardiovascular risk factor. Soluble intercellular adhesion molecule 1. These are proteins that cause the white blood cells to adhere to the artery wall and initiate plaque formation. And there was a significant drop in those proteins. There was a significant drop in the hemoglobin A1C, the average blood sugar, with the Ultramil low glycemic index diet. And there was a 26% drop in fasting insulin. So two diets, same number of calories, but the results are very different because of what's going into making up those calories. These are some things to take away with you, things that are particularly important when it comes to cardiovascular risk. Mediterranean-style diet. I have a newsletter that goes a little bit into the Mediterranean-style diet. That's what I teach patients in the office. It's a whole foods, minimally processed, varied diet. It has a lot of plant foods, lean protein, olive oil, maybe a little red wine. It's low in glycemic index. It's a diet that's blood sugar friendly. Exercise. Exercise is extremely important. Exercise is anti-inflammatory, works in multiple ways to reduce cardiovascular risk. Quitting smoking is probably the most important thing a person can do for their cardiovascular health. Achieve ideal body composition. So if you have too much fat, you need to reduce your fat. If you don't have enough muscle, you need to build muscle. And I offer testing in my office that measures those body tissues. It's one thing to have an ideal weight, but if your weight is made up of too much fat, not enough muscle, that's not healthy. Stress reduction, for some people that's critical. Omega-3 fatty acids, everybody should be getting fish oil. If you eat cold water fish, you don't need to supplement as much. Then have a comprehensive biochemical workup, including the VAP profile and independent cardiovascular risk factors, maybe including the specialized ADMA. look at nutrient deficiencies, then you can personalize your diet, lifestyle, and supplements, and truly make your cardiovascular system healthier. This is what my website looks like. My website has a lot of information. I have articles on a lot of topics. I have a description of specialized tests I do. We have some patient video testimonials. We have some self-tests you can do. You can access my newsletter. You can sign up for future webinars. You can see my lecture schedule, listen to some radio interviews I've done. That's my web address. And now we're ready to open up for questions. So you can go ahead and type your questions on the right. No questions yet. I'll give it a couple of minutes. If nobody has any questions, I'll look forward to doing another webinar with you again in the near future. I send out emails if you're on my email sign-up list. If you're not, you can sign up for my website. Okay, it looks like we have one question. Is the VLDL3 connected to insulin resistance? Yes, it is. When I'm determining whether a person has insulin resistance, there are a number of things I look at. There are quite a few things on that VAT profile. VLDL3 is one. There are other things I look at as well. I look at their fasting insulin. I look at their blood sugar, look at their hemoglobin A1C, look at the uric acid, look at the liver enzymes. They have some connection. Probably some other things from the routine blood test I'm not recalling right now. And I also look at a person's waist measurement and their waist to hip ratio. We question whether they have carbohydrate sugar cravings. That's strongly connected with insulin resistance. Look at their family health history. If there's a family history of conditions associated with insulin resistance and there's a strong suspicion. And there are quite a few conditions. I have a webinar on my website called Reversing the Number One Cause of Illness, Obesity, and Accelerated Aging, all about insulin resistance. Insulin resistance contributes to diabetes, heart disease, Alzheimer's disease, colon cancer, breast cancer, prostate cancer, osteoporosis, autoimmune disease, polycystic ovary syndrome, many conditions. And then we could also do a glucose insulin tolerance test. That's a very sensitive test. You go to the laboratory, fasting, they draw a blood sample for sugar and blood sugar and insulin. You consume a high carbohydrate meal, then over the next few hours you get more levels of glucose and insulin measured. And if your insulin goes up too high and stays too high, that's an indication of insulin resistance. Okay. I think that does it for the questions. Thank you all for attending, and I'll look forward to doing this again with you soon. I hope you got something out of it. Thanks again. Have a good night.